Thank you for the invitation to Oscar and for the committee. It's a pleasure to be here, and it's very difficult for me to talk after Avelino Barjon. He's a great surgeon, and he's also a friend of mine. But he is used to do these big surgeries in these patients. But this is my disclosures. How common are the metastases in a spine? It's very common. More than half of the patient at the end of the day will have spinal metastasis, and 1/3 of them will have in the cervical spine. Well, then we need to treat all the patients? No, we don't need to treat all the patients from a surgical or oncological point of view. We need to treat the symptoms of the patient. We don't need. We were discussing with other neurosurgeon before, we need to treat the patients, not the MRIs or the CT or whatever. It's more important the quality of life of the patient and the neurological status than the imaging or the number of metastases that you can resect. Cervical pain is one of the main points: radicular pain, spinal cord syndrome, and deformity. There are different surgical indications, but what's evidence-based said to us? Well, in 2005, there were a study conducted making the comparison between radiotherapy against laminectomy and radiotherapy. At the middle point of the recruitment of the patients, they stopped to do that because the difference between two groups was 85% of the patients with surgery were able to walk, and only 57% of the patients with radiotherapy were able to walk. And this one was one of the main things that produced long survival in the patients. They stopped. Then we need. These are the charts, and you see how different are both of them. This is a very good review about treatment of spinal metastasis. Has been published in neurosurgery. It was written by Mark Bitsky, who he's a neurosurgeon, and he developed all these skills that Avelino has spoken before. In the in the 2008-2009, radiosurgery came into the field to develop all these things and to change the way that we thought about resistant tumors. This is the classification that he has talked before, and the current NOMS decision framework, how to treat these patients. But it's not real science. Sometimes there's a state of art, because it depends not only about the surgery, also in the hospital that you are working, the possibility to do SBRT or a lot of other things. What type of surgery can we do? We can do all the surgeries that he has done with big resection and reconstruction of the spine, but you can do also laminectomy plus fusion. Anterior approaches also can be done in the cervical spine. Cement augmentation has been used in the late 20th century and also in the next years, in the recent years. And separation surgery plus SSRT and minimal access surgery is something new that we can take into account. And radiofrequency ablation has been proven in the last 2 to 3 years. Well, the main thing that we can say is our goal is to have the patient without pain. These are the charts. And also, when you are doing posterior decompression and spinal stabilization, and increase of the neurological status in the UAS score. But the prognostic factors are the type of primary cancer, if it's radiosurgery resistant or not. Ambulatory status is second. how spread is the tumor, not only in bones, also in visceral. And this point is very important. How many complications has this patient? Each patient, because with big surgeries, more than 50% could lead a complication. In normal fusion, even 25% can afford this patient to have these complications, to be in the hospital for 1 month to resolve an infection of the wound. I think they cannot afford that, and we cannot give them this type of complications. This is a typical case of a patient with 45 years old, lung cancer, unable to walk, laminectomy and fusion. Also, anterior approach can be used to reduce the tumor and to put some cement augmentations. Cement augmentation, all of us have to use it. All of us have been used for vertebral supported fractures because it's the most common indication now. But the first indication was hemangiomas in the 1987 and has been treated metastatic disease for a long time in lumbar and thoracic, very easily from posterior. But in cervical spine, you cannot use the posterior approach because the stroker is thicker than the pedicle. Then you need to treat in another way. It has been published in the last 10 years about anterior approach and kyphoplasty to enlarge the fracture to give a good space to put the cement in it. You can do also in subaxial spine. Here you have the result with CT. There is some leakage. It's important, the leakage. Well, all the results are excellent. Only one bad in this. There are four serious polyps. The reduction in VAS is 6 points. It's huge reduction. It's huge impact in the quality of life of these patients. And the number of complications, there are around 33% of leakage, or 60% in the other case. But any one of these produce any symptoms for the patients. You can also put a screw on it. Separation technique plus radiosurgery is something that changed the idea to treat these patients. We know that there are tumors more resistant than the others to the radiotherapy. With the classical techniques in radiotherapy, this kind of tumor on the right, you cannot treat because you cannot reach the radiotherapy level that you need to destroy the tumor without lesion the spinal cord. Then you can do it, all of this with radiotherapy, even around the spinal cord, but you need 2-3 millimeters of separation. You can do this, for example, in this case, you can do, this is a huge chordoma operated 3 times with 2 types of radiotherapy and compression of the spinal cord and tetraplegic. You can offer something to this patient. Is it unstable? Who wants to operate this patient after 2 surgeries, 2 radiotherapies? Nobody? Me neither. But you can do this radiosurgery. This is the result. We haven't cured this patient. She was able to walk again, but she died 5 months later on. But you can give them quality of life without pain and ability to walk. Thank you for your attention.